Thank you, Dr. Ragab. Bismillah ar-Rahman ar-Rahim. Good afternoon, dear professor and colleagues. My talk today is about overreading of mitral annular disjunction in cardiac MRI. Mitral annular disjunction is characterized by inappropriate detachment of the mitral valve annulus from the underlying mitral valve myocardial tissue. This condition plays a crucial role in assessing cardiac function and associated pathology. In total, the available studies suggest that the prevalence of mitral annular disjunction is between 16 to 55% in patients with mitral valve prolapse and or severe mitral regurg. A recent systematic review of 12 studies reported a pooled prevalence of mitral annular disjunction of 30% in patients with mitral valve prolapse and or Parlos disease and 8.7% for general population. The identification of mitral annular disjunction during cardiac imaging has significant clinical implication. It correlates with adverse cardiovascular outcomes, including arrhythmia and heart failure. As we used to know that mitral annular disjunction is usually associated with mitral valve prolapse and can be associated with severe mitral regurg, also other forms of mitral regurg, either mild or moderate. The cardiac MRI is considered the best modality for diagnosis of mitral annular disjunction as it utilizes various imaging techniques, including the cine images, late gadolinium enhancement, and ET1 mapping. These methods facilitate the assessment of myocardial tissue characterization and abnormal displacement of the posterior mitral annulus away from the left ventricular myocardium. The most important sequence to diagnose mitral annular disjunction is cine images, especially three-chamber view and three-chamber stack and LVOT stack. As we can see here, this is a three-chamber view. There is a separation of the posterior mitral leaflet from the basal lateral wall of the left ventricle. Late gadolinium enhancement also is used to ensure the diagnosis of mitral annular disjunction. As we can see here, that there is patchy enhancement at the lateral wall of the left ventricle and the site of detachment or the site of disjunction. So mitral annular disjunction is characterized by displacement of the mitral annulus or the posterior mitral valve leaflet from its normal position, which is detectable through MRI. The key indicator is abnormal annular distance measurements during systole and diastole, which are critical for diagnosis. So before we diagnose mitral annular disjunction, we have to know how to diagnose a mitral valve prolapse. First, to diagnose a mitral valve prolapse, we have to draw this imaginary line which represents the mitral annulus. It starts from the hinge point. The hinge point is the point where the posterior mitral valve leaflet attached to the basal lateral wall of the left ventricle. This is the start point from the hinge point and ends at the aortomitral junction. So when we draw this line, this represents the mitral annulus. So to diagnose mitral valve prolapse, first we have to see a second mitral valve. Also, when we measure the distance from the mitral annulus to the dome of the posterior mitral valve leaflet, it should be more than 5 millimeters. If it's more for 5 millimeters, this is a classic case of mitral valve prolapse. Another measurement we have to know is the papillary annular distance. Normally, this distance is about 12 to 16 millimeter during systole and more than 22 millimeter during diastole. If this distance more than 16 millimeter in systole and 22 millimeter in diastole, this ensures the diagnosis of the mitral valve prolapse. After diagnosing mitral valve prolapse, we should look for the mitral annular disjunction. As we said before, there is a great association between the mitral valve prolapse and the mitral annular disjunction. As we can see here, there is detachment of the posterior mitral valve leaflet from the basal lateral wall of the left ventricle, which is very appreciated during systole and slightly appreciating during diastole. A detachment more than 1 millimeter ensures diagnosis of mitral annular disjunction. As we said before, there is a 3-chamber view. We could see a posterior detachment of the posterior mitral valve leaflet from the left ventricular wall. And in late gadolinium enhancement, we could see that there is patch enhancement at the lateral wall and the hinge point or the site of detachment. An article was published in October 2024 in the Journal of the American Society of Echocardiography by Fiore, Riza, and Angelina, stated that 84% of the cases classified as mitral annular disjunction were identified as pseudo-mitral annular disjunction. So what is pseudo-mitral annular disjunction and what is the true mitral annular disjunction? We can see here there is a detachment of the posterior mitral valve leaflet from the left ventricular wall or myocardium, which can be appreciated only during systole, but cannot be appreciated during diastole. As you can see here, that the posterior mitral valve leaflet is adherent to the LV wall or myocardium. But in true mitral annular disjunction, there is detachment of the posterior mitral valve leaflet in both systole and diastole. As we could see here, there is a minimal detachment seen of the posterior mitral valve leaflet from the LV myocardium. What was shocking in this article that we noticed that the severe mitral regurg is least to be associated with true mitral annular disjunction. It's more common to occur in mitral valve prolapse only without mitral annular disjunction and pseudo mitral annular disjunction. Also, other forms of mild or moderate mitral regurg are more associated with mitral valve prolapse and less associated with true mitral annular disjunction. These findings raise critical questions. What exactly was defined as mitral annular disjunction in previous studies linking this condition to arrhythmic risk? What we used to diagnose before as a mitral annular disjunction? Could the term disjunction often be misleading? Understanding the distinction between the pseudo-mitral annular disjunction and true mitral annular disjunction is essential for better risk stratification and patient management in mitral valve prolapse. Thank you.
شكرا دكتور عمرو for the very